Good. Well, it is just gone 12:30, so welcome everybody to this Public Trust Board meeting today. I'm Jackie Smith. I'm the chair here at BHRUT for anybody who is new, and particularly warm welcome today to Marta Phillips, who's joining us for her first board meeting as a new non-exec director. And Marta will also be joining the Finance Committee, so you are very welcome. We've also got Justin Daniels, who's the Acting Chief Medical Officer, up to the point when Mamta Vadia joins us as Chief Medical Officer on the 16th of May. And we've got Caroline van Lapma, who's joined as part of the team, focusing particularly for a period of 6 months on our emergency pathway and improvements that we can make there. I think I also saw a note from Catherine that we've got 2 Chief Nurse Fellows today, Sophia Murphy and Mark, joining to experience the joys of a board meeting. You are very, very welcome. Good. Okay, let's go on to apologies for absence. We haven't received any. Is that still the case, Linda?
Yes, it is, yes.
Good, okay, thank you. We've got the updates to the Board of Directors declarations of interest, which are in the papers for everybody to see. So let's move on to the approval of the minutes of the previous meeting, which was held on the previous public board meeting, which was held on the 8th of March. And I will go through them a page at a time, and we will please put your hand up or shout if there is anything that you want to see corrected in the minutes. Okay, so page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11, page 12, page 13, page 14, page 15. Okay, nobody signalled, so I am taking that the minutes are a correct record. We have the action log as well. Linda, do you just want to briefly update if there's anything that we need to note from the action log?
Yeah, thank you. Catherine was going to give an update on the matter arising from the patient story that we received at the last meeting.
So since the last meeting, I've looked at how people can raise concerns, and that we've got lots of different ways. But I've noted that in a number of other organisations, if there's an estate type issue, they have a sort of notice on the wall that says this is the phone number to bring. So I was going to explore that further, because I think that's probably more what we were talking about at the board meeting last week, rather than we have a staff concern around patients, other staff behaviour or patients' behaviour, or a concern around clinical care. So I was going to continue to pursue that with the Estates Department, if that's okay.
Thank you, Catherine. Thanks for that. Good. Okay, that's everything that was on the action that isn't either not yet in time or hasn't already been dealt with. So that's good. it's probably just worth noting as well that we would usually have a patient or staff story at the beginning of our public board, but unfortunately the patient that was due to be coming today is not able to attend, so we haven't got one today, but I hope we will be back to that again at our next public board. Just to come on to my update, I just wanted to start actually by reflecting on the fact that many of us who now sort of travel around and are venturing out will have seen that there's very clear evidence for people that, thank goodness, we do appear to be coming to the end of the COVID pandemic. And I just wanted to note, however, that many people, the process of the, particularly the sort of lockdown periods, was a time when people were able to retreat from the melee of their everyday life. And although it was very difficult for everybody, it tended to be a sort of period almost of sort of enforced quiet away from the things that we would normally do, travelling, socialising, working with others. Of course, for our staff, it was exactly the opposite. As many people were stepping down and stepping back, our staff were stepping forward in order to work in the most difficult circumstances and enormously hard over the last 2 years. And as we move from the pandemic period, hopefully, to the post-pandemic period, it hasn't been possible for our staff to stop and take a break and rest in the way that I think all of us would have wanted them to, because of course we now face the challenge of getting our services back up and running fully, and of course of addressing the backlogs that have arisen in the course of the pandemic. And so I just wanted to place on record my way in which our staff responded, not only through the pandemic, but also as we recover from it as well. And I just think it's important sometimes that people outside the NHS understand the nature of the experience that those people inside the NHS, including directors and leaders in this meeting today, have gone through, and that we record our appreciation for that. In terms of the board, we've seen some important developments. I've welcomed Marta already because this is her first meeting, but it's also the first public meeting where Mahbub is appearing as our new vice chair of the trust board. So of course Mahbub was already a NED, but in the process of recruiting vice chairs for each of the trusts that I chair, Mahbub was successful in becoming the vice chair here at BHRUT, and you're very welcome to your new role, Mahbub, and Mahbub will also be chairing the finance committee as well. Similarly, at BARTS, we've recruited a vice chair as in the form of Adam Sharples. And although I've welcomed her previously, Leslie Seary, who of course is one of our non-exec directors, is also now a joint non-exec director sitting on the BARTS Health Board as well. The other important development today is that people will remember at the March board, I reported that in the light of the decision of the chief executive of BARTS Health, Dame Olwyn Williams, to retire at the end of July, we have decided as the boards of the two trusts to recruit a group chief executive to have responsibility as accountable officer over BARTS Health and BHRUT. Following a great amount of interest, a very strong shortlist, international interest in fact, I'm delighted to have been able to announce today the appointment of Shane Dagaris as the first group chief executive officer leading the two organisations. Shane's been the deputy CEO at BARTS Health for the last 4 years, leading on the operational performance of the hospital group. Prior to that, he was the CEO of Hillingdon Hospitals NHS Foundation Trust, and he'll take over in August. when Olwyn Williams formally steps down from her role as CEO at BARTS and single accounting officer for the collaboration with BHRUT. I'm very confident that Shane's appointment will help us to provide, during the difficult time that I've just been alluding to, some really stable and effective leadership across BHRUT and BARTS Health at this crucial time. Whilst, of course, Matthew will continue to provide trust leadership here at BHRUT in his role as Chief Executive of this trust, and of course in reporting to this board on the progress that is being made as well. I'm very much looking forward to working with Shane, and I'm sure we all are, to further develop the collaboration between the two trusts in order to deliver that very straightforward purpose that we've set for the collaboration, that it makes it more likely that wherever you live as one of our patients across the catchment areas of both trusts, you will be more confident of being able to get quick access to the best quality care and the highest possible outcomes for health wherever you live. We have reported progress on the collaboration in this board previously. We've updated publicly, and of course we have accounted to scrutiny bodies in local authorities for the progress that we're making on the collaboration. But tomorrow, for the first time, the two boards of the two trusts will be able to actually meet together to review progress with the collaboration so far and to think about the priorities for the coming year, and I'm very much looking forward to that. Just a few other things that I've been able to do since the last time that we met in public. On the 14th of March, I visited Barking Community Hospital with Matthew and Catherine Thompson to see the whole range of activity that is going on there. And of course, we have discussed the developments and the investment that will be being made at Barking Community Hospital. And of course, the Secretary of State, Sally Jarvid, has visited as well since then. On the 11th of April, with Matthew, I, at Queen's, met with Julia Doe, the Head of Patient Administration, and went to look at the enormous amount of work in our outpatient departments for those administering and preparing for the clinics and helping that to be a smooth process both for our patients and for our clinicians. On Monday, the 25th of April, and Matthew mentions this as well in his report, we had the pleasure of attending BHRUT's Long Service Awards, an event aimed at recognising and celebrating the service and the commitment and the skills of staff who've shown their loyalty to the trust over very many years. We presented awards for people who've been with us for 20 years and for 30 years. It was a very lovely and cheerful event, and really nice to be able to celebrate our staff and their families, who of course provide such important support to them whilst they work here. And then this morning I was able to participate in a workshop organised by the North East London Integrated Care System, where we looked at approaches to prevention and financial elements, not the detail of our finances, but thinking about how we might want to ensure that our finances focused on those areas of greatest need across the ICS. It's very good to see the ICS developing, and I think the challenge for us all is to ensure that the potential impact on particularly tackling health inequalities is realised as the ICS moves into its statutory and fully functioning role. And also, since we last met in public, I have continued alongside Matthew to brief particularly local authorities, local councillors and politicians about developments across our patch. So immediately after the last meeting, Matthew and I attended the Redbridge Health Scrutiny Committee, and on the 10th of March we both attended the Outer North East London Joint Health Overview and Scrutiny Committees, where I was able to provide a verbal update on our collaboration with BARTS Health, including what was agreed as part of the MOU that we published last year, and was able to talk about some of the tangible benefits that we were already beginning to see from that collaboration. And we were able to respond to questions on all sorts of aspects of our performance and developments. So that will do for my update. Are there any questions on that before I move on to Matthew's? Okay, thank you, Matthew.
Hi, thanks very much, Jackie. And just first of all, just want to say congratulations to Shane. I've worked closely with Shane for a number of years and got a good working relationship with him. I'm really looking forward to working with him across BHRUT and BARTS, very much with a focus on getting the best possible clinical benefits out of our collaboration for our population. And as Jackie said, it was a good field actually. And we met some really interesting people as a result of it. But it's great news to have Shane coming in, a guy who knows North East London very well, and with his clinical background as well, very much focused on patient care and quality. So you'll have read my report, so I'm not going to run through it all. A couple of highlights for me. One is we've now opened both of our new ITUs. So some of you will have been fortunate enough as spectators rather than patients to see the Jubilee ITU at Queen's, which is beautiful, you know, top floor set in, lovely big windows with natural light, and talking to the staff there, including quite a few who've returned to ITU. In fact, now that we've moved them into such a good facility, it's a really fantastic environment for patients and their families actually when people are critically ill. And we've now, as of last week, opened our new 12-bedded ITU at King George Hospital as well, which similarly is built to a very high standard in terms of infection prevention and control. Again, one of the great things about the King George site as well, lots of natural light there too, and some really innovative design done there to make sure that we get the best possible use out the space there. And actually talking to the teams, you know, nursing, clinical, etc., pharmacy and so on, they've all been heavily involved in the design of it, and you can tell, you know, it's a clinically designed and led space. And what I think was really impressive was talking to Rajesh Jain, who's our lead consultant, and Michelle, who's been leading the work on the sort of nursing and ops side, is that it's been around 10 months from conception to delivery of the project. And I think pre-pandemic, I'd have penciled in 3 years to build a new ITU in an NHS hospital. I spent 2 years trying to move a phlebotomy outpatients to put a 4-bedded discharge bay in one of my previous jobs. And I do think there's something about the way in which the pandemic, well, it has undoubtedly caused enormous harm. It's also shown us some things about the way the service works, actually. And I think the fact that we've now got at King George Hospital a new emergency department, a new ITU, we're hoping to expand our theatre capacity there. And actually, with the move of the ITU into its new space, we're now going to have Clover Ward there, which was previously a paediatric ward, available to use for working age adult patients as well. We're seeing the estate there really expand to start to meet the demands of the local community. So real good news there. And one or two other things, we're continuing to deal with some really significant pressures on the emergency departments and very visibly in the queue for the urgent treatment centre at both of our sites. We're starting this week at Queen's a new model of front door triage. This came off the back of the CQC inspection report that I think you'll hear more about from Catherine and I later today. But one of the risks they identified, and one of the risks any of you who've been into either of our hospitals will have spotted, is the large number of walk-in patients who are waiting to be seen and registered and triaged. And there are, you know, most of those people, you know, the majority of them are at the right level to be seen in primary care or within the urgent treatment centre. A minority of them need to be seen within an emergency department, and a very small number of them are very unwell. And you know, we've got good at spotting those very sick people and picking them out of the queue. Unfortunately, we've become a bit too good at it as a response to what is quite a lot of risk that's carried in that front door model that CQC recognised. And I'm pleased that this week, with the support of our colleagues at East London GPs who run PELC, and their new chief exec, Steve Rubery, and our own ED team, Kareem Ahmed, James Avery and Scott and others in Queen's, we're starting some joint front door triage. So people who arrive at the site are going to be seen jointly by the urgent treatment centre team alongside a senior member of the ED staff, so we can make that senior decision-making model that we've been really keen to try to promote in the emergency department. We're going to be trying that out at the front door as a kind of proof of concept, really. It's what the Royal College of Emergency Medicine says we should be doing. And if that works, and I expect it will, I'm hoping that it's going to improve the way in which we manage safety and risk in the department. I hope it'll improve our decision making about who does come onto the site, and that we can use that to try to address some of the pressure points within the emergency pathway. And ultimately, I really hope that it helps us address those safety concerns that I think all of us can see there in real time as we come through the front door at Queen's. And if we can get it working there, we'll want to get it working at King George as well as soon as we can too. So next board, I'll be able to tell you a bit more about that. And also the ambulance receiving centre, which you'll all be aware of from previous reports, has now saved over 10,000 hours in paramedic time. So from the LAS perspective, that's been a really significant success in terms of getting crews back onto the floor while we do the longer term work to create more capacity within the trust and try to create more flow. So I think they were probably the main points I wanted to pull out of my report, Chair. There's quite a lot else in there that people can read through, and I'm very happy to answer questions on. But I think that's probably the core stuff I wanted to draw attention to. Just to finish by saying thanks once again to the surgical teams. They've continued to do some amazing work. On Saturday, they all came in on Saturday and saw and treated 200 people who were on the hernia outpatients list. Last Thursday, in one of the Queen's theatres, they put on a sort of Formula One style day with some really intense attention to flow and managed to run 7 pretty complex procedures through one ward. I spoke to the team a couple of days before it, and they were all really fired up for it, and we're delighted about the way it's gone. And I was pleased to see again last week that we've now been in the top 2 trusts in London for most of the last month now, in fact, for high volume, low complexity surgery volumes. And the surgical teams are really working hard. You know, so we had the blow around the increase in the waiting list because of the ERS data problem that we identified. But I think we've got teams in surgery and across planned care who are really pulling out all the stops. And it's good to see this innovation in both emergency and urgent care. Hopefully setting us on course for a much better service for our residents and for our staff in the years to come. Thank you, Chair.
Thank you, Matthew. That is enormously encouraging stuff that the surgical teams are doing. I mean, as you say, leading the way for very many other trusts, not just across London, but across the country to look at. Good. Are there any other questions or comments on Matthew's report? Okay, sorry, Sue. Thank you.
Thanks, Jackie. Not a question, just a couple of comments, if I may. One, to say how fantastic it is that all those capital developments have been delivered, and I think we should make a special point of praise to the estates team and the finance team for creating really powerful business cases and then implementing and delivering at the pace that Matthew said. There's a lot of back office folk involved in supporting the clinicians, and I'd just like to give them credit. And the second thing I wanted to say was I was fortunate enough to have already arranged to come to Queen's last Friday, which was the no meetings day, to spend time with the managed equipment service, and I just wanted to say what a fantastic time it was. The fact that people could get out and about and meet with staff and not have the pressure of rushing back to a diary commitment. I would absolutely support that initiative happening on a regular basis, if at all possible. Thank you.
What, like the second Tuesday of the month, for example?
Or the last Friday of the month, some schedule, yes.
Matthew.
Yeah, I mean, the no meetings day, and thanks to Amalesh and Ben Moran for really suggesting that. I mean, it was fantastic, actually. I mean, it always really strikes me when I look at my calendar that I tend to do somewhere north of 30 hours of meetings a week. And actually, it was a day where there was very high visibility of all leadership levels right across the trust, actually. And there was a real buzz about the place because, you know, and it's there is something we've got to learn about this. About how we try to get better decision making within the trusts. Actually, it was, you know, Teams offers us some great opportunities to get people together at very short notice across geographies that just wouldn't be possible otherwise, and it saves all that travel time that you otherwise lose. But I think it's become a bit too easy to fill every half hour of people's days with Teams meetings, and we do it almost without thinking enough these days. And it was one of the most energizing days I've had since I joined the trust, actually. So thanks to the folks that suggested it, and I think we're doing a roundup of it, and we're going to make some suggestions about how we make it a fairly regular feature, as well as improving our day-to-day management of our time and resource.
So thank you for that. Thank you for noting as well all of the people involved in bringing the capital developments to fruition. And on the subject of visiting the trust and being able to do things that aren't just meetings. I'm very hopeful that next month, when we have the board seminar, we'll be able to do that in person in the trust, and that we'll be able to be getting back to board members, particularly non-exec directors, being able to actually come into the trust to visit, to talk with staff and patients, and to do that really, really important triangulation that comes from that engagement, as well as obviously the data and the other reports that we receive in these board meetings. Good. Let's move on to the quality and safety part of the agenda. Quality Assurance Committee reports, first of all. Jackie, I think you're going to give us a verbal update on the key points from the meetings held in March and April.
Yeah, I will do. So as you said, we've had 2 meetings since the last public board meeting. On the March meeting, there's nothing particularly we want to escalate. We discussed the CQC inspection report at for the emergency department at Queen's, and obviously that was on the agenda at the board. But what we did agree at the March meeting was that we wanted to undertake a series of deep dives, which I think, as you say, Jackie, now that we are a bit more able to come in, you know, I think we felt it was quite important that we start to do a bit more deep diving around topics. And the first one that we're going to do actually is maternity. And Joan has been very much involved with the maternity department, pulling together a 1-hour session for us at our next meeting to really understand where we are with maternity, which I think will be very helpful. We also identified how we're keeping people safe whilst they're waiting in our emergency departments, also medicines management, where we noticed a few things that we want to investigate further, and potentially sepsis and fall. So we've got a bit more of a sort of schedule of things to look at. From the April meeting, there were a few topics that we did want to escalate. Actually, one Matthew has already mentioned, which is the delays in ambulance handovers. I know that the new approach with London Ambulance Service is helping, and Matthew just referred to that. But I think certainly when we were doing our meeting in April, I think there was still a real sense that this is something that, you know, continues to be a risk for the organisation. So that's one thing. The second thing actually was with respect to radiology. So what we're seeing in radiology is an unprecedented demand for their services. They recognise this in the divisional risk register, and actually the mitigation include building in some additional capacity, but also actually bringing in a radiology consultancy company who are going to work with the service to support them to design an improvement programme, and that will be reported back to Quality Assurance Committee in May. And a couple of other points that we're seeing non-compliance with the Department of Health mixed sex accommodation breach rate, which means patients are at risk of unjustified mixing of genders in their sleeping accommodation. It's one of the risks on our risk register, but in March we had a total of 43 mixed sex accommodation breaches, and we lost 96 bed days for critical care. And actually, finally, on a very important point to recognise that at that point, BHRUT and the North East London Cancer Alliance was the only region nationally to meet the 28-day faster diagnostic standard, and really recognition about the hard work and tenacity of the team that has delivered what is obviously a fantastic result for patients. And we had a number of papers that I won't talk any further about because they're on our agenda for today. So thank you.
Jackie, are there any comments or questions on that? Okay, let's move on then, and we've got the report on the very important final report from the Ockenden review that I think you're going to introduce.
Yes, thank you very much indeed. So I brought a number of reports to the board on Ockenden. We've also had a number at the Quality Assurance Committee, and obviously we review these through the Maternity Assurance meeting. The first report was published in March, and I brought the paper which details how we dealt with the first 7 emerging actions from there. And this is really to talk about the 15 actions that we have to address going forward. We've put the detail around exactly what's required within the paper, which I hope people have found helpful. But I thought it would be more helpful for me to describe what we're going to do next and what our actions are going to be. So it's quite clear within the Ockenden paper that we need to work much more as a multidisciplinary team. So historically, action plans have been developed by individual professional groups, so the doctors or the nurses. So we're really starting to bring the groups together so that we can have an MDT team. I'd just like to say that we have got the new team within maternity, which is really, really helpful. We've got the leadership team for the women's and child. We have Catherine Tomset, who's the doctor. We have Abby, who is the director of midwifery, and Nikki, who is the divisional manager. And they together are really starting to pull things together and get our plans in a very robust position, which I think is very helpful. We also have a new head of midwifery who's an operational lead and a head of midwifery for governance. So that sort of leadership team is looking much stronger than it has for some while, and I'm pleased that they're starting to bed in it and working together really well. But that's the team who are going to bring together our action plans. One of the key areas that's highlighted within the report is staffing, and we have currently got about 34 vacancies for midwives within the organisation. We have 22 student midwives who are going to qualify in September, so I'm very keen that we keep positions open for them, because having invested our time and effort in training our new midwives, we want to be able to make sure that we're able to provide them with jobs. So there'll be a slight hiatus whilst they arrive, and we'll fill those posts with bank or agency, but that's the reason that we haven't gone for additional recruitment. But that will still leave us with a shortfall, so we're going to international recruitment for 15 to 18 midwives. We did this with the Capital Midwife Programme. We recruited 16 midwives who should have been here by now, but only 2 of them are actually going to arrive, which is why we're doing our own recruitment, because we feel that we have a good track record in delivering nurses when we do it by ourselves, and we're going to use the same company to do the midwives, and they should be here by mid-June. So I think that that would be very helpful. But in the Ockenden letters that we've had from Jackie Dunkley-Bennett, who is the Chief Midwifery Officer, she's been clear that maternity continuity of carer teams, which provide care for women from antenatal into delivery and out into the postnatal wards, should be suspended until such time as our staffing levels are high enough to make sure that all women have the right care that they need. So we will be suspending that in some areas until early next year, when we've got our new recruits in, they're up, running and embedded within our organisation. We've got some new leaders for our Maternity Voices Partnership who are really proactive, and we haven't had this actually for 2 years, so it's absolutely brilliant that they've joined us. They're really helping with our diversity of women who are accessing our services and have come up with some really helpful suggestions. So we're going to have a focus every month looking at a different element of pregnancy for women, and each week the same sessions are going to be presented in various formats, various languages, so that they can meet the needs of our local population. So that's something really new for us. We haven't been proactive in doing that before. We have quite a lot of information that is translated into different languages, but the opportunity to converse with people in different languages is new for us. So I'm really excited about that. Just one point to note, it says quite clearly that we have to have labour ward labour ward leaders training. There is no national training for labour ward leaders, but I've spoken to our maternity support partner this morning, and we're going to develop our own training, and that will be piloted with all of the organisations who are being supported by this particular scheme. So I'm happy to take any questions. Hope that's helpful.
Thank you, Kathy. Are there questions? Martin.
Thanks very much. I have to declare a partial interest in this, in that I'm on the Nursing and Midwifery Council, so I'm a little bit more aware of the Ockenden work than other subject matters on this agenda. And so one of the things I was reflecting on as I was reading the report and also listening to the presentation, and thank you very much for that, is this whole issue about resources, which you did mention, and the fact that there will be a number of currently trainee midwives coming on to hopefully our permanent staff, because clearly they've got a choice as to whether they work here or they go elsewhere, but hopefully they'll decide to work with us. And I was just wondering about their support in their newly qualified status, because again, that does take additional staff resource. So it's this whole kind of resources piece that has already been commented on as to how we will manage it, because I'm not entirely sure that those midwives, newly qualified midwives coming onto our permanent staff, excuse me, will result in the additional resource I think was implied by the presentation. So I think there's a little bit more fine tuning to do for the resource plan. Thank you.
Within the organisation, we have a really robust preceptorship programme. It's a year-long preceptorship programme, and it's accredited to master's level. So it takes in leadership, quality improvement, etc. So all of our new midwives will go through that programme, in addition to their local programme, which is obviously about their maternity competencies that they develop as they join us as permanent members of staff.
Ben.
Thank you. So I hope this helpfully builds on the points that Martin made and Catherine as well. I'm a member of the London People Board, and one thing that's been striking looking forward to the data on projected vacancy levels in London in the next few years is the challenges we may face in relation to midwifery. And one of the great opportunities, I think, of the collaboration, not just with Barts Health and BHRUT, but with partners beyond, is to think about midwifery and supply, because there's little doubt that otherwise a lack of collaborative focus and thinking about how we can work more intensely with academic partners, with partners at community level, will leave trust in a really tricky position in terms of the vacancies that they'll otherwise face. And I think just going back to something that Jackie said at the start of the meeting, there's little doubt, given the popularity and the pressures facing the team, of how much they've needed to confront and face during the pandemic, as a team that's working extremely hard. And I think it's really looking for us to do our very best to help them with the resourcing challenges they're facing at all levels. So the leadership that Catherine referred to with Catherine Thompson and the divisional team, and not least new midwives joining the team and listening to their perspectives, will help us a lot. But an area that we need to keep in really, really clear focus, facing the whole of NHS, particularly in London, in the next few years.
Thank you, Ben. Joan.
Hi, Chair. I'm having some connection difficulties, so I'm going to try and put my camera, but hoping you can hear me. The issue around support, which is mentioned, I think is quite a crucial issue. Having seen the midwives, we can, as Catherine said, talk about a much higher level of assurance than we've had before, because there's a lot of work going into making sure we are attracting midwives who will go somewhere else. And so a lot of work going into how do we get local new trainees to stay. There are also issues around the rota and how we can make the rota easier for people. The rotations are done in a particular way, and I know there's work going on to look at how we make sure that changes. And then there are issues around just making sure there is cover on the wards of an appropriate nature. And so the team have done that, but we're looking at scaling that up to more permanency. Again, as Ben said, these are issues happening across the NHS, but we think at BHRUT, particularly with the local community that we have, with the diversity of staff, we should be doing better on attracting and keeping those staff. So in a multidisciplinary way, there is more work on that. And I'm glad to see that Marta will be bringing a professional eye to that area as well. Lastly, I think there is much interest from the maternity multidisciplinary team in knowing that because of Ockenden, there are going to be major changes. That may involve some financial resource, as has been indicated already. And so we hope to know more in the deep dive that we'll have at the Quality Board. Hope that's helpful.
Thank you, Joan. And I think most people know, but just to reiterate, Joan is our board maternity champion, if that's the right word. So thank you for that, Joan. Catherine?
Yes, I suppose the other thing that I perhaps should have mentioned is our commitment to apprenticeships in terms of growing our own staff. So Greenwich University is one of the only areas that provides midwifery training via an apprenticeship route. We do a lot of apprenticeship training via for the nurses, but we have got a number of people on that, and that's enabled people who've been working with us for some time as maternity care support workers or healthcare assistants to access that training. They wouldn't necessarily have had the opportunity to give up their job, give up working, and go to university and train in the traditional university route. So I'm really pleased that we've been able to get people onto that, and we will continue to do that. It's quite a long course, it's 3 years, whereas the top up for nurses is 18 months, so that makes it quite a long time for people to do it. But we have currently got 3 people on that programme and a number of others who are interested and are going to come on behind in terms of that. So I think we just need to keep being committed to our local population to enable them to access work with us in a role that they really want to do. So thank you.
That's great, thank you. Thank you, Catherine. It's both an opportunity for us and an opportunity for our local communities if we can find imaginative and different ways to encourage people to come into a whole range of work in maternity, but particularly as midwives, and that's really encouraging that we're sort of leading. Okay, let's move on then to the just the update on the Care Quality Commission inspection at ED, and as Jackie says, this has been reviewed at the Quality Assurance Committee as well.
Thank you. So I think this is just a relatively quick review because I think I have talked about this a number of times before, but we have now got our final report, our final CQC report, which was published on the 4th of March. We didn't have any of our ratings downgraded, which we were really pleased about, and we only had a number of should do's in the report. Sorry. The continuing oversight of the CQC action plan will be taken by the ED Assurance Board, and that we don't have any date for future inspections. We thought that they might come back quite quickly. They have inspected HELC on a couple of occasions, but there's no indication that the CQC are coming back to inspect our ED departments anytime in the near future. I won't go through the detail because I think people have had an opportunity to review it previously, but I'm happy to take any questions.
Thank you, Catherine. You're right. We have looked at this in detail previously, although, as you say, this is the final report, and probably just worth reminding ourselves that despite the enormous pressure that the inspectors that the department was under, they also recognised the real efforts and enthusiasm that our staff were showing in responding to that, and made the important point that this is something that needs to be dealt with on a system basis, not just by us as well, particularly in terms of the demand that we're facing. Okay, let's move on then to the perinatal deaths review for Q4, which has also been reviewed by the committee.
Thank you.
You've gone quiet, Catherine.
Sorry, I'm sorry. The next 2 reports are reports that I'm going to be working with the new Director of Midwifery on in some detail. I think what we have here is a sort of list of things that have happened, but we don't have the learning or the changes that we've made as a result of these reviews. I think that there are 2 key things that I would like to just raise in the first report, and one of those is around women with gestational diabetes. We know that since the new Director of Midwifery has been in post, she's spent a lot of time with the diabetic team. They are really, really stretched because of the population we serve. We have lots of women who come in with diabetes, and we need to think about our capacity within that team, and we will be reviewing that over the coming months. We also, in a number of these incidents, it talks about people being given information via newsletters and emails. On a number of walkabouts I've undertaken recently, I'm not entirely sure that people are having time to read all of those emails or to look at all those notice boards. So we're changing that so that we're going to have far more huddles where people can discuss incidents and learn rather than being asked to read lots of things. So the report is here for consideration, but as I say, I think we've got some work to do on making this more meaningful for the board.
Thank you. The serious incidents report, Catherine.
It keeps turning off. So I think that the same really in terms of this report. You've got the list of the incidents as they happened. We're not an outlier in terms.
Turned off again.
It just seems to be turning itself off. That's very strange. Sorry, I'm not anywhere near it. So I don't quite know where you were. So again, this is just a report which I think needs a lot more work on it. And now I have the new Director of Midwifery in post. I think that we will be able to bring the next report, which has got a lot more detail around learning and actions that we're taking, as opposed to a sort of list of the incidents that occurred.
That's great. Good. I think that's a very good development, because the important thing for us as a board is to be able to both review the incidents, but more importantly, to be able to consider the actions from that and the closing of the loop in terms of the learning. Marta.
Thank you. We really welcome the comment you made about how information was actually being disseminated in huddles rather than sending people loads of emails and reports to read. But the thought crossed my mind is what steps would be put in place to make sure that everybody gets the same messages, because the risk with delivering information verbally, it sort of depends on who's delivering the message as to exactly what gets said and where the emphasis is placed. So I'd be interested in your comments on that, please.
Thank you. I think maternity is quite interesting, because across the rest of the organisation, most of the information for serious incidences has been disseminated via huddles for some time. Actually, there isn't a very great reliance on email traffic. And our evidence, which is really, if we ask the staff on the ward about their latest serious incidents, what's the learning, they can talk to us about that and they can tell us the answers to those questions. So we don't have a specific format in which people relay the information. It tends to be more of a discussion of the incident and the changes that have been made, and that is generally led by the lead, so the ward manager, either the band 7 or the band 6 on the ward. It doesn't happen in that way in maternity, and that's what we're trying to implement. But I think it's a good point in terms of how can we be sure everybody's hearing the same information. On the wards, everybody has the same written information, so the information related to the serious incident is available in written format, but they also do it in the narrative and the discursive way. So I think it would be interesting for me to go in and think about that and perhaps test that out a bit on the wards and see if there's anything we need to do differently. Thank you.
Good. Okay. Let's move on to the first of the integrated reports that we have, and this is the integrated quality and safety report, which people have in their packs. And Catherine, I'm sure you will draw out the key points for us. Thank you.
Thank you very much indeed. So if I just take you through the key highlights, I think, from this report. Firstly, I think that Jackie's already mentioned the ambulance offloads. That continues to be an issue for us and is absolutely linked to patient flow, which is some of the work that's being worked on. And I think Matthew mentioned that in his report, but that continues to be a concern for us. We have a number of serious incidents, investigations in progress. Some of those are breaching. We didn't prior to COVID, this was never an issue for us. It has become an issue during COVID. We've absolutely focused really closely on complaints, and we now have no breaches on complaints, and we're using the same approach with the serious incidents to get them back under the target dates. I think that during COVID, we were able to pause our serious incident investigations, which has meant that people have been having to deal with a higher volume of serious incident issues. What I think is positive is that the new serious incidents that are being declared are not reaching. It's the old serious incidents. So we are working quite closely, and we've got some external help to help us get back on track with that. We're doing a lot of training on the new patient safety incident response framework. I think everybody on the board's been invited to those training sessions, and if people are able to attend, that would be really good. I'm very happy to recirculate those if that would be helpful. We're able to have volunteers back in the organisation, which is a really good news. We like our volunteers and our patient partners, and we've got 20 new volunteers who've joined us over the last couple of months, which is really helpful. As I say, the complaints we've now got to their normal positions, so we're seeing those in a timely fashion, so families and relatives and patients aren't being kept waiting for the responses to their complaints. We're also seeing a slight deterioration, or slight improvement, I suppose, slight reduction in the number of complaints that we're seeing, not by a marked amount, but it is definitely coming down. We've had quite a lot of people who are retiring and returning at the moment because of the changes in the pension rules. Fortunately, most people are choosing to return, but not necessarily on the same hours that they were doing prior to their return. So whilst that's just settling down, we'll see what impact that has on our workforce. And we know about 30 midwives have taken up this opportunity, so that is another issue that we're dealing with in the maternity department. I think the detail is in the report for people, and I'm happy to take any questions.
Thank you, Catherine. Are there any questions on that integrated quality and safety report? No? Okay, let's move on then. Onto the people and culture items, and Leslie will be giving us a verbal update from the People and Culture Committee held in April.
Yes, thank you. So that committee meeting focused very heavily on the people framework and the staff survey results. We looked at the final draft content for 4 of the 6 elements of the people strategy around education, learning and development, modernised employment practices and wellbeing. And those proposals had been fairly extensively tested with and informed by the staff networks, the trade unions and our partners in the wider system. And we looked at that framework in the context of the 2021 staff survey results. And so that was probably in the forefront of the committee's minds as they were thinking about the people strategy. And indeed, I think that was something that we focused on fairly extensively the day after the committee when we had the board seminar and looked at a lot of these issues. We talked quite a lot about work being undertaken to support the well-being of our staff and how we might improve that, and talked about relaunching the My Conversations. And I think what was positive about that was that the 90% target for My Conversations had been achieved. And indeed, there was feedback from medical colleagues that they wanted to be part of the process, whereas they hadn't been previously because the GMC has its own appraisal process. So from this year, we're going to include medical staff as part of that. And rather than rating people against values, but actually to reflect and have discussion on the trust's values and have that as more of an engagement about what people feel about the values and how people feel they are performing against those values. So that by now, I think we should have relaunched that, because Ben is nodding. So yes, because I know the target was for the end of April, beginning of May. There were, and we normally do have quite a lot of discussions about the importance of ensuring that the senior leadership of the organisation, and Matthew picked this up in terms of both the board and senior executive leadership in his report earlier on, but that senior leadership of the organisation actually much better reflects the staff, but also the communities that we represent. And so we were talking about a programme for all leaders, an aligned programme for all band 7s, so that we can think more about how we actually make sure that we are both supporting, developing and enabling staff to be able to compete successfully for senior level roles, particularly focusing on women and those staff from BAME communities, which are the areas where the data shows us, and Joan is rightly always points us to what the data is showing us, but the data shows us that in particular areas it is both women and in other areas BAME staff who are the ones that are not reaching the levels in the organisations that they should do. So that was really the focus, and as I said, a lot of that was picked up at the board seminar the following day.
Go on then, Laura.
Hi, yeah, it's Laura Finkelson. I just wanted to say, since that Jackie and Matthew has come on board, we have made some strides with regards to staff morale. So I just wanted to acknowledge that. The feedback that I've been getting is that the staff make the same comments and there's a distinct lack of action, and that is why they feel disengaged. So I'm just basically asking, can we provide assurances that there will be an action plan and there will be further progress?
And I should say that's exactly what the committee said too, and I know Ben's got his hand up, but that's what the committee nudges, prods Ben and colleagues all the time, that we actually need to be responding. Quite often issues get raised through the trade unions or the staff networks, and the perception is that they disappear somewhere and nothing ever comes out the other end again. And we've talked about talking much more to people about what is happening and what progress is being made, rather than just not communicating with people. I'll let Ben answer, but rest assured, we do probably, to Ben's irritation sometimes, we do bang on about this quite a bit at the committee with Ben.
Ben never gets irritated, do you, Ben?
Yeah, no, I genuinely don't feel irritated. I think it's a really important point. It's so fundamental, isn't it? Because the framework means nothing, a strategy means nothing unless it leads to real change, and that's felt in someone's life and their experience working here. So the people framework, as many of you will be bored of seeing it, is, I think, pretty clear about a range of defined targets, not just in terms of what we achieve in terms of an output, but an outcome and a date. And I think it's fair to say that in relation to one core area, we need to, and we will, bring forward action more quickly than we've said, and that's around the cost of living crisis, as well as saying all the things that we said we would focus on at the start of the year and through the trialling of the people framework. We need to be agile enough to recognise those things that need greater focus and more speed, and that's an area that we're devoting resources to. The other thing I'd say, and I hope it helps, is that it's going to be really critically important to work and recognise the fit of the framework with that of partners. So we've had some really good conversation in the last few weeks with Daniel Waldron and colleagues at Barts Health and other colleagues close to us about how we ensure consistency and learn from each other and align some of the changes we're thinking about together, so they have real value for colleagues across our communities, but they also allow for a greater degree of consistency that helps people move and work across our organisation, not just in the NHS, but around it. So Laura, I think it's a really fair point, and one I hope you will see that we're really focused on. And your ability to hold us to account and visit us and see us at executive level and talk to us about this feedback directly is really important too. One final quick observation. I've been encouraged to think with national colleagues around how we can get our national NHS staff survey results quicker. I picked that up with a responsible national director, and they're keen to work with us to find a solution. I press that we get them within 24 hours. It might not be possible to do that, but we are working with them to see how we can get rid of this delay issue, which I think for many is quite frustrating, including for them. Let's see what we can do. We'll keep you in touch.
Thank you, Ben. Leslie?
Just to say, picking up on the my conversation issue, we talked before about, learning from each other across both Barts and ourselves, and one of the encouraging things was listening to a conversation at Barts around appraisal where it didn't feel as positive, and being able to suggest to them that they might want to contact BHRUT, because the work that we put in place over a year ago now around My Conversation has actually been really quite successful in terms of engaging staff in a very different way. So sometimes it feels to people on the sort of this side that they know everything in Barts and we don't, but it was really nice to be able to say, actually, you need to talk to BHRUT because they've done work on this one and it's actually looking really successful and the staff feedback is positive. So it's kind of nice to have the learning go two ways.
That's absolutely true that happened, and that it is. So thank you for that, Leslie. Okay, let's move on to the finance and performance section of the report, and the Finance, Investment and Performance Committee. Mahbub will give a verbal update from the meetings in March and April of any issues that needed to be escalated. Thank you, Mahbub.
Okay, thank you, Jackie. And the March meeting was on the 30th of March, the April meeting on the 27th of April. Both were quorate and chaired by George Wood, Associate Non-Exec Director. I wasn't at the 30th of March meeting and observed the 27th of April meeting. So at the 30th of March meeting, the strategic outline case for EPR was discussed and subsequently approved by private board on the 12th of April. The other investment item was Barking Community Hospital Diagnostic Centre. The OBC was discussed and subsequently then approved after some deliberations at private board on the 12th of April. And the extension of the non-emergency patient transport contract was agreed as well. At the April meeting, the committee received 3 business cases which were considered and are on the agenda for later at board meeting today. This was the Bank Partners Contract Full Business Case, an OBC for a development known as the Ice Rink Strategic Development, nothing to do with winter sports, can I add. And the third item is the BARTS and BHRUT collaborative for non-emergency transport and courier service, which I'm sure we'll have opportunity to discuss further today. The meetings do consider standard items, which include the integrated performance report, which we've got next on the agenda, and the monthly finance report. And colleagues will be aware that the underlying deficit was £6 million per month in 2021-22, and the year-end deficit was at 76 million, an increase from the year before. The plan is to achieve £5 million in a month deficit for 22-23, and a range between 60 million and 65 million outturn deficit for this year end. There's a good position on capital and cash. The other standard items considered were non-elective recovery report, elective efficiency report, and workforce control programme report. The key escalations from the most recent meeting is around the work to address stranded patients. The data showed a huge increase in those patients who are staying 21 days plus more since 2020. I was on a couple of ward visits with Catherine, to whom I'm very grateful, for a 6 AM week before last and a 10 PM last week. And perhaps you'll continue to meet with me in those antisocial hours, or maybe not. We'll see how that goes forward. But one of the things that was clear is the number of patients that we have who should not be in hospital. Hospital isn't the best place for them. Matthew presented findings of a workshop at the last FIC meeting, which were pretty significant to show that these patients seem to be with us acting as a kind of cottage hospital, and they would be far better for them to be elsewhere and receiving the type of care that they need and not in a costly hospital bed. And the significant discussion was about ensuring that we can improve type 1 performance in ED if we were to have improved flow through the wards, including a morning discharge. And in order to achieve a morning discharge, decisions would have to be taken up on 4 p.m. the previous day. And there isn't a consistent approach towards those type of clinical decisions on patients who are optimized and able to leave, and quite often the decisions lag during the course of the day, and we find that on an evening those patients who should have been discharged in the morning are still with us. And on the day, on the second of the visits I had, Catherine and colleagues had been dealing with a critical crisis during the day where we just simply ran out of beds. We had a shortage of something like 75 beds, and patients were not in the beds that they ought to be in and had been in trolleys for far too long. And sort of links to a point that Jackie made in providing the Quality Assurance Committee report about looking a deep dive into ensuring the safety of patients who are awaiting treatment in EDI, but also obviously once they've been treated, looking at their safety pre-admission towards. We're carrying out a deep dive in the June meeting into EDI and urgent care, and that's the report, Jackie, albeit secondhand from attending the meeting in April.
Thanks, Mahbub. Is there anything that people want to comment on in relation to that? Okay, let's move on to the integrated performance report, which is in your papers. Richard, is it you drawing out the key points in this?
Thanks, Jackie. Can I just check everyone can hear me okay? Good, excellent. So I'll just pull out some of the key points around 4 hours RTT and cancer, if I may. So from a 4-hour point of view, we started to see some improvement in type 1 performance during March, which is the data in your pack. So 4% improvement at trust level and 6% at King George for type 1, as I say. I think Matthew's already touched on some of the front door process changes that are being planned, and Mahbub also on the work on early discharges. So perhaps just touch briefly on some of the structural changes. We've opened our emergency decision unit at King George, so this is for patients requiring a short period of observation or treatment. We've continued to maintain extra beds at King George that we opened during winter. And also we've got a sort of minimum of 15 additional short stay beds on Sky A at Queen's now in place. So colleagues may want to touch on some of the other changes that we're proposing as well. Going forward, we can see some green shoots of success from the enhanced same-day emergency care facility that we talked about in previous meetings, and we'll be looking to replicate that at King George's in due course. As I say, there's been good early outputs from Sky A ward changes. So this is the short stay medical ward. We'll be looking for full opening later on in the year. So I'll move to RTT now. So it's worth noting the data pack in March doesn't reflect the additional patients that were dropped off as a result of the incident we declared. So this is related to the management of our patients on the National Electronic Referral Management System. And this was described in Matthew's report in a bit more detail. So it's worth noting from an April point of view, you'll start to see the impact on that incident, particularly affecting the 52-week numbers and also our performance. From a governance perspective, so we want to fully take stock of the impact of this incident. So one of our non-exec directors will be chairing fortnightly meetings of an incident working group. So we'll be looking both at the impact on patients, so from the perspective of long waiters, but also reviewing any harm, and importantly making sure we learn any lessons from this. It's just worth pointing out our teams are already making really good progress on putting on the additional capacity to see these longest waiting patients. So as of today, we've got 107 patients waiting over 104 weeks. And we're putting on capacity to treat these longest waiting patients by the end of June. But as well, it's probably worth stating that we do expect a small number to be waiting, largely as a result of patient choice into July. Finally, on cancer, so we've again met the FDS standard in February and expect to do the same for March. We've made really good progress on our 62-day backlog. So we've been working really hard to put on additional capacity to reduce those patients waiting over 62 days on the cancer pathways. And the important point in that is that will help to improve our 62-day performance going into this financial year. I'll pause there for any questions. Thank you, Jackie.
Thank you, Richard. Are there any questions on that or any other aspects of the report? No? Okay. Yeah, Sue.
Sorry, I had a little computer glitch. Richard, we've heard about quite a lot of front door improvements. I was just wondering whether you've got any data on what that means for length of stay in A&E, and are we seeing that improve now, or is it too early to tell? Thank you.
Yeah, so we do have evidence that suggests that some of the measures we've taken are reducing length of stay in ED in particular, so starting to impact 12-hour waits, for example. So I'm very happy to share that through relevant committees in a bit more detail soon. But yeah, certainly there has been an initial impact.
Thank you.
Good, thank you for that. It's probably also worthwhile saying that we will be, as a board, in our next seminar, looking in more detail at some of the planning and thinking around the UEC pathway, which is something I know that internally people have had the opportunity to do as well. So that would be something very interesting and important for us to be able to get our teeth into. Jackie.
Yeah, thank you. Quick one from me. I think Matthew mentioned ambulance handovers. I mentioned it. We were concerned about it in the Quality Assurance Committee, and looking at these graphs, it doesn't look as if things are particularly improving, or that maybe that sort of growth may be levelling off. And Richard, it would be really helpful if you could share with us, you know, what you're seeing now, and when you think that all of the work that's being done, which I know is considerable, will impact the ambulance handover breaches.
Thanks. I mean, I think it's fair to say that it comes in fits and starts. So what Mahbub had described a couple of days ago, the experience of essentially being short of beds at certain points in the day, and that has a knock-on effect in terms of the flow in the hospital and the ambulance handovers, and that's when we really begin to struggle. Certainly, we are seeing the impact of the ambulance receiving centre. So I think Matthew's already touched on the additional hours that's been handed back to LAS as a result of that. So we're seeing 1,400 patients through that unit already. So there are things we're doing to try and cover that. I see Matthew's got his hand up, so I'm sure he's got more to add.
Matthew.
Yeah, I mean, there's a couple of things with the ambulance numbers, and you know, you see our numbers on their own. It's relative to other services as well, sometimes in terms of where our position is. There's a couple of things we've also picked up in there. One is people will be aware that ambulances go direct to the frailty unit and offload there, and actually they are no longer counted in our denominator. So every ambulance that arrives at the site that goes directly to the frailty unit, and therefore the patient doesn't wait for the handover, that's been taken out of our denominator. And Nick and I have been looking at some of those performance metrics with Ben Conway, and I think it's fair to say there'd be a really quite material change in our performance in terms of the percentage of breaches if we started to include that data. And we're also looking to include the East of England as well. And ultimately, though, the fact remains people are waiting too long on the ambulances at times. And it goes back to the point Mahbub raised earlier, which is we do have a real problem with the quite congested pathway through the whole hospital. It's particularly been influenced by increased length of stay. More than 80% of our occupied bed days are now taken up by people whose length of stay is over 7 days. So we are trying to run the shorter stay acute element of the acute hospital through a fraction of our total bed base, which is what's backing up into the front end of the hospital. And I think we're going to invite the board to do the walkthrough of the full set of metrics that we've shared with our staff to try to engage with some of this issue. But yeah, certainly on the ambulances, there's a lot more for us to do there. And one of the real positives that's come from it is the change in the atmosphere in the emergency department. No, really, you know, the relationship between LAS and our AD teams was a real flashpoint because of those real delays and lack of capacity in the department. And there's been some real improvements in that as a result of the teams working together to develop the joint model for the ambulance receiving centre, which has also proved popular with some of the LAS staff. It's interesting, there's quite a few paramedics I've spoken to down there who are now doing regular shifts in the ARC within the hospital. They said they're learning different skill sets. We're learning from them as well. And I've spoken to one or two of them who said they were thinking about retiring fairly shortly, but actually, because they can now do the work within a specific setting, they're keen to do more work with us on that. So it's really helped us in that relationship with LAS. Ultimately, we've got to sort out the long waits, though, because it's rotten for patients and particularly frightening, I think, for people who are out there waiting. I mean, London's doing best in the country on Category 2 response times, but they're still nowhere near where any of us would like them to be. And as the acute hospital, we're very conscious of the role we play in those delays.
Thank you.
Thank you, Matthew. Richard. So, finance report, Nick.
Yeah, good afternoon, everyone. Mike actually is happy to take us through this, if that's okay, Chair.
Okay, thank you, Nick.
Thanks, Jackie.
Thanks, everyone. Afternoon. I think key figures to note. We actually landed both the revenue and the capital position to plan, which is fantastic. Subsequent to landing it to plan, we were asked to play our part in landing the London regional position, which meant we actually underspent our capital by 600,000 and overspent our revenue by 600,000. But overall, we did what we needed to do, so that's really good news. As Mahbub pointed out, the underlying position does remain at about 6 million deficit a month, and that's the figure we really need to focus on, because that's where all of our waste manifests, and we know that we need to tackle that through our elective recovery and through our equitable and affordable bank and agency rates predominantly. We heard a bit about capital earlier. We spent 43 million in the year, which again is fantastic, and that brings the last 3 years to 100 million, which is more than 3 times what we were able to spend in the preceding 3 years. So really, really good development in accessing capital and enabling both backlog and transformational change. So that's really good news. The cash position is healthy. So we had 75 million in the bank at the end of the month. Some of that is to pay off the capital that we've delivered in the last few months, and will normalise out at about 40 to 50 million as we go into the new year. And we're very, very keen that we improve our payment of suppliers. So we're currently at 92% within terms, which is very good, but we want to get to 95% and above because we have the cash. So it's just process improvement. I think they're probably the key headlines, Jackie. I'm happy to take questions.
Thank you. There aren't any. Good. Let's come on to the corporate governance section then. And Audit and Risk Committee, the report was distributed yesterday. Sue will update on anything that needs to be brought to the board's attention.
Thank you, Chair. So yes, the report is now included in the pack, covers agendas of 2 meetings that we've had since the last public board meeting. Just to highlight, we received 4 internal audit reports, 2 giving partial assurance, 2 giving substantial assurance. We also received the annual report from our internal auditors, head of internal audit opinion. We achieved a significant assurance with minor improvements, which is a good outcome from our internal audit process. But our internal auditors were quite keen to emphasise that in the spectrum of organisations that achieve that rating, there is a range, and we as an organisation were towards the bottom of that range. So whilst it's a great outcome, we have work to do and should not remain complacent. In terms of counter fraud, we've just gone through a process to appoint new counter fraud consultants to us. We've appointed for 1 year to enable a levelling up of contract year end so that we can look in a year's time at a system-wide solution for counter fraud services. External audit is well underway. The interim has been completed, and to date everything is on track for what I hope will be a much more streamlined external audit. And we were given an update about one of the technical matters that gave us difficulty last year relating to pensions, which is moving forward but is not yet fully resolved. So we will have to have further updates on that. There's various other components in the summary report, but I think those are the main highlights. So happy to take any questions. Thank you.
Thank you, Sue. Are there any questions or comments on that? No? Okay, thank you. We have the use of the trust seal, which is, I think, largely just for approval, unless anybody has got any questions on that. Okay, I will take that as approved. Risks identified during the meeting. I mean, clearly we've considered a range of issues, including around performance and quality, but I don't believe that there are any of those risks which aren't actually already incorporated quite clearly within our risk register and our board assurance framework, unless Linda wants to suggest to me differently.
No.
No? Okay, good. That brings us to any other business, probably. And then we will come on to questions from the public, if we have any. Worthwhile noting that this is Remy's last meeting with us as part of the BHRUT board before she moves across to be the medical director at Whipps Cross in the Barts Health Group. Remy, thank you for your contribution, and particularly for the focus that you have rightly brought to the board and to the organisation around diversity and inclusion, and I think helped us to make some very important progress on that. And obviously we know we're not losing you. We're looking forward to working with you in your new role. Thank you for your contribution in BHRUT. Leslie?
I just wanted to say, as sort of chair of the People and Culture Committee, a huge thank you to Remy. Remy has just been an absolute driving force in the change that we've been trying to deliver, and just a real personal support to me as chair in trying to move the agenda forward. And I'm really, really grateful. It was kind of new role, and you've shaped that role in such a way that, you know, I can't imagine us not having somebody in that role now after the way in which you've led it. So thank you, a personal thanks for everything that you've done, Remy.
Remy.
I was just going to put something in the chat. Thank you very much to everyone who has really gotten on board with this uncharted territory of the director for EDI and supporting and developing not just myself but the networks in shaping that agenda. Thank you to Ben, particularly with the People's Framework, and to Matthew, whose error I have sort of twisted and turned many times. And I hope that as these green shoots have come forward, that we will build on them. So thank you very much, Chair. been a pleasure.
Thank you, Granny, for your contribution. That brings us to meeting effectiveness. It's probably worthwhile noting that this is particularly short. Marta, I don't want you to have the impression that we usually skip through as quickly as this, but I think both the absence of a patient story and the fact that several of the things that we've considered today are things that have previously been on the agenda and have been well gone over by the committees means that we've gone through a little bit more quickly than we would usually do. As I say, don't get lulled into a false sense of security. That brings us on to questions from the public. We haven't had any notified in advance, although Andy, I note that you tweeted that you wanted to ask one, so fire away. You're on mute.
Thank you very much, Chair, for allowing a couple of questions. Well, I might as well mention them straight away. The first one is an update on the 40-bed shortfall, whether you've got those beds reopened, and the second one is whether you've got discretion to help people who aren't eligible for public funds, whether that's an absolute. So those 2 points, if you could expand on those, I'd be grateful. And the third point, if you take this one without any notice, there was mention of a service being suspended. I didn't really quite understand what service is being suspended. Is it a consequence of Ogaden? Is it throughout England? I'll be grateful for some clarity on that, please, Chair.
Okay, Matthew's going to start with responding to those.
Sure, thank you. And thanks for the questions. Some good points in there. So on the beds then, first of all, you'll recall that at the start of the winter, we were hoping to open a significant number of beds, both within our site and in the community, but we were facing some real staffing challenges. And so the Sky A ward, which has been available to us within Queen's since the end of last calendar year, we've now got that open as a short stay acute assessment unit, which we're flexing it between 15 and 30 beds. So when we had a difficult weekend like the one just gone, we're using it on a Sunday to try to alleviate pressure and get people through the weekend. We'll be opening it permanently to 30 beds, we hope, by the autumn, when we've got recruitment completed. So we've certainly got 15 and 30 available steady state. We're seeing some really good results on length of stay actually in that ward. It's working to the model we'd hoped, but full staffing for that will be later this year. And we'd also been working with NELF to try to open the stroke community unit, Daisy ward at Goodmays. Unfortunately, NELF were unable to staff that. We've now staffed that with some of our own staff through the stroke team, and that's just opened this week to 7 beds. It's got the capacity to go up to 15. Again, due to staffing issues, we're not going to be able to go beyond that 7 initially as well. And we mentioned also earlier the Clover ward at King George site is now available as a result of the move of the intensive care unit. Prior to its use as an intensive care unit, it was able to have 18 patients in it. It needs repainting. It needs quite a lot of work doing on it. I mean, it was a paediatric ward previously, so we've had ITU beds in there surrounded by some very colourful artwork on the wall, really, and it's not the best, most appropriate environment. So we need to repaint that, refit it out again. But my hope is that'll give us 18 general and acute adult beds, but with the clinical model still to be decided at the King George site. So certainly, in terms of what's hard beds available now, 15 in Sky and 7 on the stroke unit. Still got a way to go on that, and we're keen to see more of that capacity opened up. We're also starting to have a think about next winter, given how hard it's been to staff these wards this time, and we've been having some very good discussions with some of our local directors of adult social services about looking at some of the unused care home capacity in the community, for example, where care homes have closed and gone out of the market in the last couple of years, and whether there's some other options we should explore going into the winter. Because, you know, I was sat there in October thinking, great, we might be able to get 60 beds into the system this winter. It just hasn't happened. And I think it would be foolishness to assume that we could approach next winter, assuming we can pull so many new staff into the hospital environment when they just aren't there. We're going to have to think about different ways of caring for some of our long stay patients. The other 2 points, the eligibility from public funds. I know we've had a difficult case in the local press where a woman and her young child have been hit with a very large bill for NHS services. There is very little discretion in terms of that. The law of the land is that if you're not eligible under certain terms of residency, it's nothing to do with having an NHS number. You can have an NHS number and still have to pay for NHS care if you don't meet the residency criteria. And unfortunately, this woman's now been hit with a very serious bill for that. We do look into all these cases to see what we can do, but we do have a duty to recover that money. And unless there's changes to legislation, which would be a matter for Parliament and for the service nationally, we're in a pretty tough position then. And the problem is, pretty much every case I see, you could make a compassionate grounds for exempting the family involved, and it's a horrible situation to find ourselves in, really. And the risk is, you end up making judgments about who's more worthy than the next person in terms of receiving an exemption from this, and it's a slippery slope that gets us into difficult circumstances. So the law of the land at the minute is that we need to recover those costs from people who are not eligible to receive free NHS treatment, and to make sure that that funding is available to invest in people who are eligible for fully funded treatment. The third point was about the continuity of care issue, which is a result of the Ockenden report. Continuity of care is a model of care where you have a much lower ratio of mothers to midwives in the community. So a typical community midwifery service might have a ratio of around one midwife to 150 up to even 200 mothers. Under continuity of care, you get much smaller ratio. It's down in the 30s typically, which is getting closer to what you see actually in an inpatient ward, and it's undoubtedly a very good service. And the issue we have at the minute is of our around 300 midwives, we're running at a 10% vacancy rate. And the area we've been trying the continuity of care service, it's been very successful. It's actually one of the areas within our footprint that's got some of the lowest risk mothers in it. And we're in a position where we're having to make some decisions about where we concentrate our resources to provide the best possible support to the women that we know are at highest risk of coming to harm during pregnancy and childbirth. I'll be putting something out in my stakeholder newsletter later this week, and we'll be communicating with some of the affected areas. What I should say is that any women who are beyond 28 weeks and who are already in the system for that, they will not be losing that, and no women will be losing their access to community midwifery services. It's just that we're going to make sure that we can improve some ratios in some very stretched parts of our footprint by taking this service out of some other bits for a short period of time until we get the staffing sorted. So as ever with these things, it's about us balancing risk and trying to make sure that the people we know who are most vulnerable to harm during maternity and during that period of pregnancy and childbirth are getting the best services that they can. So there'll be more information on that coming out to everyone later this week. And once we've got the numbers up, I'd love to see continuity of care available to more women in our footprint. We know it works well. And I think actually when you look at some of the deprivation that we deal with in some parts of our patch, it'd be great to see us concentrating those resources there. I mean, we had a big conversation in the ICS this morning about dealing with inequity and dealing with health inequalities. And actually, we need to make sure that we are targeting those resources in the place where actually the benefit to the mothers involved will be most proportionate. So thanks for the questions, and I'll address certainly that latter point in my public newsletter on Friday this week.
Thank you very much.
Thank you.
Thank you, Matthew. Thank you, Andy. We don't have any other questions from the public, so we will complete the public board meeting there, and those of us who are in the Part 2 board will meet again at 3:15. Thank you, everybody, for that. See you later.
Bye.